For joining us. This is, as you know, the Frontiers in Child Health Research Seminar. Our seminar is held on the second and fourth Mondays from September through June and includes speakers with work focused on child health from both UCSF as well as guest speakers. Please let me know via email if you're interested in speaking or would like to suggest a speaker. Looking ahead to our next speaker, not today, we will be welcoming Dr. Adam Numis from the Division of Epilepsy in the Department of Neurology. We are still virtual and using Zoom, so we'll ask that you stay muted unless you have a question, and we'll also open it up at the end to questions. Today, we're welcoming Dr. Liz Rogers from the Division of Neonatology. Liz is a professor of pediatrics, the Associate Vice Chair for Faculty Development in the Department of Pediatrics, and the department's Chief Experience Officer. She's the director of the Intensive Care Nursery Roots Small Baby Program and the co-director of the Intensive Care Nursery Follow-up Program for the California Perinatal Quality Care Collaborative. Liz's research focuses broadly on outcomes following extreme prematurity, neurodevelopmental outcomes in other high-risk neonatal populations, and health equity. She's funded for some of this work by NICHD as well as other sources. The title of her talk today is Metabolic Function in Preterm Neonates, Predicting Maturity, Mortality, and Morbidity. Thanks so much for joining us.
Awesome. Thank you, Roberta, for the invitation. And it's great to see a bunch of colleagues on for whom this talk may not be new information, but I hope it stimulates conversation. And certainly, I know Roberta mentioned taking questions at the end, and perhaps we're a big enough group where that is the most efficient. But if there is something burning that comes up as we talk through, I'm more than happy to take questions also as we go. So along with other hats that Roberta mentioned, one of my scholarly foci that I'm going to share with you today is looking at metabolic function in preterm newborns, and particularly trying to understand how metabolic function gives us a window into predicting maturity, mortality, and morbidity in this high-risk population. And again, I see a lot of my neonatal colleagues for whom maybe a review of preterm birth is not necessary, but for the rest of you who maybe haven't been on the third floor for a while, I will say actually for some of you, it might actually be new news that preterm birth really now is considered any birth prior to 37 weeks, that we think about this threshold where resuscitative measures can be employed as being sort of a national standard between 20 and 25 weeks. And these other categorizations of prematurity, where early preterm birth can be less than 32 weeks. We also have different classifications that consider preterm birth, different varying levels, less than sort of 34 to 37 being late preterm birth. And then the term window is really narrowed, but really now consists of about 38 to 41 weeks. And the area that I really focus on in a lot of my work is this extremely or extraordinarily preterm birth, being 25 weeks and less. Today, we're going to look more sort of broadly at preterm birth amongst these various categories. And why is this important? Again, as a brief review, we know that preterm birth has an impact on the development of all of our organ systems and holistically for an infant and their family, that throughout the sort of developmental life course, we see that aberrations due to just being born early and also due to the care that's required at the time of preterm birth, there are implications and complications that can result from that, so that we're in a constant state of trying to protect the development of a growing preterm infant, avoid or prevent any acquired injuries that are likely due to the care that's necessary, and then promote the positive development that we know is so important, both for an infant individually and physiologically, but for also her family unit. So we know when injury happens, we see significant impact like from intraventricular hemorrhage or white matter injury of prematurity, certainly retinopathy of prematurity, necrotizing enterocolitis as a common and unfortunate, well, not always common, but devastating complication of prematurity that we talk about, and then chronic lung disease or bronchopulmonary dysplasia. So when we look at preterm birth, we look not just at survival, but at the development of these significant complications. And we know that this is important worldwide. This is unfortunately from the WHO, we get information a little bit scattered and a little bit later, but this is really not that different 10 years later in terms of a vast majority of deaths due to preterm birth globally, and preterm birth complications, as well as intrapartum related deaths, particularly due to things like asphyxia in low and middle income countries, but also neonatal infections I'll draw your attention to. And really, this is even just generating this graph can be difficult because we don't always understand in a global perspective whether the gestational age of a particular infant and the cause of death can be particularly difficult to ascertain based on record keeping and other factors. So what we do know is that prematurity certainly contributes globally to significant morbidity, but also likely to mortality. And we know there's a long-term impact, as I've mentioned, and some of the things that we are trying to prevent long-term in terms of physiologic complications like short gut syndrome from NEC, chronic lung disease. Certainly there's an impact on the metabolic syndrome, but neurodevelopmentally, which is one of my major interests, how can we protect the brain as it is developing and going through quite a maturation process to prevent some of the common side effects, unfortunately, of CP or cognitive challenges, learning challenges, academic, which is really a combination of a lot of different neurosensory contributors, but also significant attention and executive function aberrations. And then there's also significant mental health impact of preterm birth that is unfortunately not as well investigated as other long-term impacts, but significant anxiety, depression, even higher rates of bipolar disorder and others that needs to be further investigated. And then not to underestimate the impact on families and societies as a whole in terms of financial, emotional stress. And certainly what we know is that this is a cycle that preterm birth can be certainly cross-generational. And so trying to break that cycle is important. So what I do, what I'm trying to do with my current study, which is called PROMPT, or Predicting Maturity, Mortality, Morbidity in Preterm Newborns, is to use, I think, a slightly underutilized predictor of metabolic function as we look and apply this to how we can better understand preterm outcomes. So metabolic function has a distinct developmental pattern, and I hope to show you through several phases of the work that I've participated in that it can predict maturity. So we can actually predict how mature a pregnancy is using metabolic function. And then together with clinical factors, actually the metabolic pattern can help us predict mortality and morbidity across populations. And I see Joanna's on Halkis, one of our collaborators, combined with sort of a multi-omic approach. We think that metabolomics can lead to more precision-based measurement and care for preterm infants, which we'll talk a little bit more about. So what I hope to tell you today, really, there's a good story about the relationship between metabolic function and gestational age, to review the data associating metabolic function with outcomes of preterm birth, and to learn about how using metabolic function as a component of a precision-based approach can help us unravel etiologies and eventually help prevent complications after preterm birth. So, what we all sit and memorize for our pediatric boards and our neonatology boards and others is there certainly is a distinct metabolic profile for newborns. And this is just to remind you all and maybe to cause a little bit of post-traumatic stress disorder in you, but this is sort of looking at how does the newborn really utilize glucose, fatty acids, what's the cycle, what's involved, what are the amino acids and other, in terms of acylcarnitines particularly, do we look at when we think about how can we understand the impact of prematurity on how a baby is metabolizing or utilizing energy. And there's actually been quite a bit of work now in saying when you understand a metabolic profile, you can start to look at the impact of those metabolic networks or metabolites on newborn outcomes generally. So there was this sort of increasing recognition that the better that we understand metabolism, the better we can understand outcomes. And the great thing is that for newborns, we are already measuring metabolic function. We do it, it's mandated by all states to some degree to offer a newborn screen, which, as we know, is really meant to detect inborn errors of metabolism. But this is the current, as of 2018, current uniform screening for the state of California. So you can see, in order to screen for all of these potentially treatable disorders in the newborn period, we are getting quite a bit of information about general metabolic function, ratios of amino acids, et cetera, so that we can help diagnose these early and lead to early treatment if indicated. But there's more information here to be had. So that's what we're really focused on. And once we start seeing it, we can see how all of these things, metabolites that are outlined in orange, are involved in, are already measured as part of routine neonatal metabolic screening, but also very key to understanding neonatal morbidity and mortality. So how did we start thinking about this? This is not meant for you to totally digest the slide, but just to say, any of you remember from your pediatric or newborn well baby nursery rotations, but particularly in the ICN, about a decade or two ago, this recognition that as newborn screen expanded, both in terms of sort of populations, as well as expanded testing, it was seen that all of these newborn screens for preterm infants came back abnormal. So it was an observation being made that the gestational age influences the metabolic profile. And what we get in the nursery is a call from the newborn screen lab saying your infant has an abnormality on their newborn screen. So if you look, this is data from our collaborators in Iowa, that you'll get abnormalities between 24 and 32 weeks on, up to a quarter of infants showing an abnormality on the newborn screen. In fact, it's led to popular press. What is the PKU test? This is in sort of, online family support chats, et cetera, trying to explain why your baby who's born early, might have an abnormality on their newborn screen. But the important sort of shift in thinking about this was trying to understand, how does preterm birth affect neonatal metabolites, and why? Why are these all coming back abnormal? So particularly the patterns that we see on a newborn screen for a preterm infant is higher 17-OHP, lower TSH levels. Generally, although this varies by amino acid, but generally sort of higher concentrations of amino acids with lower concentrations of medium and long chain acyl carnitines. So all of this leading to these higher false positive rates. And this has been attributed to a number of sort of physiologic immaturity, immature adrenal and renal function, higher ACTH. But I think the question is that many smart people before me started asking was, is this abnormal? Is this really an abnormal level? Or is this just a developmental difference? And is there an underlying developmental trajectory of metabolism that we have not captured, since our newborn screen is based on term infants, in the development of these really important screening tools? And so that led this observation that maybe we could actually turn the metabolites around to predict the gestational age, rather than just saying the gestational age put them at risk for an abnormal screen, was the inspiration to the Gates Foundation, who funded these 3 studies in tandem. So again, also a great story about different ways to do research. So they funded this group here. You'll recognize names from California based on using the California birth linked data set. Iowa, Kelly Rickman and John Daigle in Iowa, and then a group in Ottawa, Canada, to essentially all investigate the same thing. And when they funded these groups to do this work, they sort of said, we're going to be publishing all of these together. So the groups went out, used their own algorithms, their own population-based data sets, but all looking at trying to use this metabolic profile in reverse. Can we flip it on its head and use it actually to predict gestational age? And they found that across the board, although they definitely had slightly different variables in their predictor algorithms, they all were able to use metabolic profile at birth to approximate gestational age in retrospective cohorts. So this becomes very interesting, and this is where I entered the group in California, where Gates then funded us to try to do this prospectively. So we have now some information around being able to use a newborn screen to predict the gestational age of a newborn. For us, that might not be that important. In the US, routinely and fairly generally, we have decent dates for the majority of the babies born that we care for, whether through good obstetric care or ultrasonography. But even we know that an ultrasound in the 3rd trimester for a pregnant person who has not had prenatal care previously can be sort of within a 3-week estimation of gestational age. So 3 weeks at 34 weeks can certainly make a difference. If we're talking that our estimated gestational age might be anywhere between 31 and 37 weeks, clearly the anticipated support that infant might need is very different. So, so we looked at taking this concept and trying to adapt it prospectively, and we're funded by the Gates Foundation to do this work in Uganda. So this is in Tororo, that's Tororo Rock, right behind. And actually there's a lot of stories to tell about this. We actually had to move. We were embedded within a birth cohort called Promote, which many of you also might be familiar with. It's Grant Dorsey and Diane Havler, as well as Ted Rule and others, were kind enough to let us come into a birth cohort that they've been studying, looking at maternal malaria. So looking at maternal malaria and different treatments, different prevention strategies in pregnancy, and whether that could prevent transmission of malaria, as well as different sort of pregnant and newborn outcomes. So we were able to come into this birth cohort with the plan to also collect metabolic profile of all of these infants to look at gestational age dating. But Tororo, where we had planned to be, it very interestingly had a widespread community plan for spraying to prevent malaria. And in fact, after that, their preterm birth rate drastically decreased. So there's been this association that's been recognized between malaria in pregnancy and preterm birth. And so in order for us to actually get the sample we needed to move out of Tororo to a smaller location called Busia, right on the Kenyan border. But again, lots of stories about and interesting questions around. We prevented preterm birth with spraying. We weren't able to do our work, but that was a great thing for that community. And what we found in this prospective study, really again working with the great ID folks at the Infectious Diseases Research Collaborative, IDRC in Uganda, was that we were able to reproduce the retrospective work of those 3 research groups, and we're able to accurately predict gestational age by using the metabolic profile at birth. So this is kind of the main story, but the details obviously are interesting. We included in this work over 650 mom-baby pairs, because this was obviously trying to generate the best obstetric estimate of gestational age. All of these pregnancies had to be dated with ultrasound. So there was ultrasound dating prior to 20 weeks in order to be enrolled in this, in the Promote birth cohort. We then obtained heel stick blood spots at birth I'll show you in a second how we got them here, but they were dried, they were frozen, they were shipped, and then tested for metabolic profile using tandem mass spec with our collaborators at the State Hygienic Laboratory at the University of Iowa. And then we actually used, when I showed you those initial 3 studies, we actually used the Rickman algorithm based in Iowa to calculate the gestational age. And then we also looked at small for gestational age, which we calculated using fetal growth curves from inner growth 21st, which is a standard LMIC technique for looking at growth. But then we also use the WHO calculator adapted to the study population, because we know SGA is a major confounder of gestational age when just using physical characteristics. So this is just a glance at sort of what our amazing collaborators in Uganda had to do, which was from Busia, to get all the samples, to dry them, to put them in this -80 container, get them to Tororo, where they then were put on a truck to Entebbe, to Kampala and Entebbe, where the airport is, flew them to San Francisco based on the way that we were funded. They all came through San Francisco, and then we rerouted them to Iowa, where they were eventually tested in Iowa. So you can imagine tandem mass spec. We'd love to get some on the African continent and a little bit closer where we could actually utilize something like this in a easier way. But we were able to do it. And essentially, when we look at preterm births specifically, you can see the vast majority of the births in this cohort were term. But by metabolic profile, about 6% were found to be preterm infants. And our algorithm based on the Rickman algorithm dated approximately 81% of newborns within 2 weeks of their ultrasound. So again, this is at the time of birth. So that's better than a 3rd trimester ultrasound and equivalent to a 2nd trimester ultrasound. And once we adapted this sort of, we then built our own algorithm for the cohort specifically. And when we utilized the Busia specific algorithm, we were able to date 90% of the infants within 2 weeks. So the preterm birth rate total was 7.2% if we used the Rickman algorithm, 4.5% when we used Busia. But interestingly, it was about 6% by ultrasound. But if you just use the gestational age for birth weight, mean measurements that are published by the WHO, it would have been 19%. So when we think about why this is important, we may not think about it as being as impactful for us, but this is huge when we're trying to think about interventions for preterm birth and LMIC communities. To really have an understanding of what the baseline rates are is super important. So you can see here that even within 1 week, the Busia specific heel stick measurements were able to date the vast majority of those pregnancies. And when we look at small gestational age, we need an algorithm that's going to be robust for SGA, because that's birth weight is what's commonly used. And so what we see is that by the inner growth standards, about 17% were considered SGA. And when we looked at Busia specific SGA criteria, it was about 13.5. But again, able to sort of think to get to take that into account when trying to predict gestational age, and do it quite successfully by applying the Busia specific algorithm. So what we found in this prospective cohort of using metabolic profile at birth to understand the age of an infant is that that heel stick metabolic modeling could be a more scalable and accurate way to measure gestational age compared to just a physical exam at birth, and certainly in the absence of ultrasound. The ultrasound determined preterm birth rate, and the model determined rates were much lower than has been previously reported and would be expected for this region. But we also have to understand this was very much in a research setting. This was a population that had to be dated prior to 20 weeks. They had access to ultrasound. As part of their enrollment in the PROMOTE cohort, as they were getting care and prophylaxis for malaria, they had frequent visits. Their births were attended. There were C-section deliveries offered. And in fact, when a pregnant person went into labor, as part of the study, there were community members who would bring them to the health center for delivery. So this was certainly a healthier population with considerably good access to prenatal and intrapartum, postpartum care. But understanding baseline preterm birth rates certainly helps in developing both sort of clinical, individual, as well as population level interventions. But this was, as I've mentioned, in a very heavily research controlled setting. So could we do this in a community setting? So the next step from this was actually to obtain funding to do a prospective work in the community. So we use the same sort of cold chain and the same protocols, but started measuring newborn metabolic profile in Iganga and Jinja, Uganda, which are large community birth centers, to really assess whether the methods employed in research conditions could be successfully implemented in broader hospital settings. And while this is still being analyzed and looking at, certainly what you can see here is that the estimates of the preterm birth rates vary quite a bit based on what algorithm you use, and obviously compared to traditional estimated estimates. So you have the Iowa model, Ottawa using their algorithm, and then what we had adapted to Busia definitely estimated a higher community preterm birth rate. And then if you look at this and compare it with birth weight, LMP, or doing sort of a Ballard physical assessment, you can see the variations. I'm just seeing, I have a chat, I want to see. Cost of doing a heel stick. It's a great question, Naomi, in terms of actual cost of it. Obviously, for us, it was very expensive to get them sent for the analysis, but the actual cost of obtaining the lab, I don't know. But certainly less expensive than ultrasound. And it's, available. Usually venipuncture is available. We just had to get the Guthrie cards to them. And that's obviously, we trained quite a research staff, but we used this amazing promote research infrastructure that was already in place. To kind of speed us along. So this has been this is fascinating to me, that we could sort of turn something around on its head and say, it's not just that these are abnormal, these actually are representing an underlying developmental trajectory of metabolism. But we didn't want to miss the opportunity for me, who's focused on development, to also understand what can we learn about metabolomics, also treatment of malaria, by doing some developmental testing in this cohort. So we used the Bailey Infant Neurodevelopmental Screener and trained the research physicians there to do this periodically in all of the enrolled infants. And what we found by looking at neurodevelopmental risk, again, the Bailey Infant Neurodevelopmental Screener is just a screener. It's easily done, which is why we chose it. But certainly just can generate a level of sort of risk. So are they low, moderate, or high risk? And in our population, we saw that the highest rates of moderate or high risk on that neurodevelopmental screener were among the preterm infants. So about 79% at 6 months were found to be moderate or high risk, but only 44% at 12 months were found to be moderate or high risk amongst the preterm infants. And really interestingly, we saw this sort of unexpected correlation with malaria infection, where at 12 months, children with mothers who'd had malaria infection were actually more likely to have a low neurodevelopmental risk profile based on the BINs, and a higher likelihood of changing risk categories to improving to low risk from 6 to 12 months. And then childhood malaria also correlated to less neurodevelopmental risk at 6 months. And the way that we are trying, the way that we've sort of understood this is that, again, this is in a very controlled research setting where they were getting quite a bit of care. And it also may have been that either a mother or a child who was getting more medical care was also getting more developmental surveillance. This group of research physicians essentially were also applying an intervention. So the difficulty with research and sort of implementation science, this group got really interested in infant development after being trained. and we're able to give anticipatory guidance. And so we think that, again, access to care may have been sort of the mediator there of the outcome. So to move on from gestational age, so we think I hopefully have convinced you and that we can actually use this as a way to look at maturity and now to understand how it might help us to look at and better understand mortality and morbidity in preterm infants. So for all this work, I'm going to walk you through these first few slides a bit more carefully, because then the next few will be based on this. But we initially wanted to look at, now that we can look at the newborn metabolic profile of all of these preterm infants, how can we use this to evaluate the ability of these profiles to predict survival beyond a week of life for our vastly most vulnerable less than 25-week gestational age infants? So for this, we, I can kind of show you over here. We use this linked maternal newborn data set, OSHPD, which is then linked to the newborn screen data. So we have all California births, and then we look at just those that have linked vital statistics and hospital discharge records in order to make sure that we have accurate data. We just control for birth weights, gestational age. We do just for this and for most of our studies, just look at our singletons. And then those that we have the tandem mass spec metabolic data available that was collected at the expected hours. And then again, we here looked at just the infants born between 22 and 25 weeks and either survived or died within the first 7 days. So this is population-based data. They all have blood spot collection within 72 hours. They're then matched to control for gestational age and birth weight. So in the end, this sample included 93 deaths and 372 controls. And when we look at both clinical and metabolic variables, you can see that we had about approximately 8 infants in this cohort die within 7 days of 8%, sorry, die within 7 days of life. Oh, let me go back. And our final model in terms of being able to predict mortality, obviously some of these things, the most important clinical factor was intraventricular hemorrhage, but also 2 amino acids, alanine and ornithine, and then 9 acylcarnitines. And again, these were all controlled for, importantly, the age of collection, understanding that this changes over time. And you can see here that alanine, ornithine, and then the 14-to-1 ratio, acylcarnitine 14-to-1 ratio were the most predictors, most robust predictors of mortality. And then when we calculate the area under the curve, I think this is fascinating. What we typically have used and standardly in neonatology to predict survival after extreme preterm birth is this characteristics only model. And there are variations of these, but essentially this includes infant sex, intraventricular hemorrhage, delivery by cesarean, and then maternal education, medical status, and then race and ethnicity. And then if you just look at metabolites only, you can see the area under the curve increases significantly in terms of the ability to predict mortality. And the combined characteristics plus metabolites is probably, again, just marginally improved with an area under the curve of 0.885 versus 0.879 for the metabolites only. So just metabolites already vastly improves our ability to predict survival. And so the way that we've looked at this is you can look at this. This is an individual baby who was included. This was an infant born at 25 weeks, birth weight pretty good, 670 grams, has no severe intraventricular hemorrhage, but the probability of survival based on our algorithm was less than 10%. And why is that? It was because of this these abnormal metabolites that were very much differed from newborns of that same gestational age and birth weight who survived. And especially this one, which was C16, which is known to have a strong association with hypoglycemia, metabolic acidosis. So although because based on our de-identified data, don't fully know why this baby died, this baby did die and was predicted because of this metabolite ratio.
Sorry, Elizabeth, just a quick question about that figure,
Yeah.
which I really like. If you go back to the heat map.
Yeah.
It seems like both extremes here are color-coded red, which I presume is bad. So is it true that like either direction deviating from the median carries a poor prognosis? I was expecting more of a straightforward sort of dose response where it's just sort of unimodal.
Yeah, no, it does seem to be bimodal. And I have another heat map coming up that might help as well. But essentially, if you think about typical concentrations and then deviating on either extreme, and for the particular amino acid or acylcarnitine, it also imports differently. So I have a different way that might help you, Ben, that looks at whether the differences are actually promotive or whether they're deleterious. I hope that's helpful. So we found was using metabolic markers significantly improves mortality predictions over clinical characteristics alone. And what we were hoping from this was that we may be able to use metabolic patterns to inform the cause of death and help elucidate molecular pathways. So specifically work that our group as well as other groups have done looking at necrotizing enterocolitis, which has definitely been a specific complication where metabolic profile has been a clear indicator. Certainly these profiles, although we're obtaining them after birth, they may aid in postnatal counseling, hopefully to inform precision-focused treatments, but also to predict sort of prognosticate with families. So what we did from there was try to look at specific morbidities. Was there, again, there had been some signal already for NEC. What about some of the other common causes of mortality in this population? Severe intraventricular hemorrhage is a major cause of mortality for extraordinarily preterm infants. So we sort of turned our attention to metabolic profile, but IVH is sort of evolving and complicated. It happens in the first week of life as we're collecting metabolic profile. So there's a lot of sort of interesting questions to ask about whether this is the right way to look at this, but we looked at it in a similar way as I walked you through previously, where we took grades of grade 3 and 4 IVH or severe IVH and matched each case to 4 controls by gestational age, birth weight, Z-scores. In the end, we had about 350 cases and 1,400 controls, looked at infant clinical characteristics that were known to be associated with intraventricular hemorrhage, as well as metabolites and ratios. And the multivariable model in the end, you'll see included these. So again, it's very similar in terms of selecting the cohort. And then you'll see that more clinical characteristics come in here than they do for survival. In particular, gestational hypertension in pregnancy, but also the need for invasive ventilation, and conversely, the use of non-invasive ventilation, which has been shown, but also these amino acids as well as C18. And so again, when we look at our typical clinical characteristics of the things that we think contribute to the development of IVH, the AUC is only 0.65, whereas the metabolite model is a bit better at 0.71. But this was a case in which when you combined clinical characteristics with metabolites, you see that you get the best prediction of all 3. So we started, this was interesting to me. This was what I wanted to do because I'm really interested in neuroprotection. Is there something that we can do initially in those first 3 days in terms of what we're providing an infant? But we started looking at essentially all of those alphabet soup that I showed you at the beginning, reminded you of complications of prematurity. We looked at BPD and ROP. We've looked at neonatal transition and neonatal encephalopathy. We've looked at mechanisms of growth restriction or being small for gestational age. And in all of these, we've sort of linked maternal biomarkers to newborn outcomes, readmissions. And so you'll see, like, rather than we started contributing like one at a time, metabolic profile seems to be a better predictor than just clinical characteristics in all of these different areas. And so rather than continuing to do this, we decided to look generally at metabolic, sorry, I have some dogs contributing, which I knew was going to happen at 12:40. I told Roberta it was going to happen at 12:40. So all these metabolic patterns, although they are different for the different conditions, they have these very distinct patterns. So we decided to look at them generally as sort of a global metabolic vulnerability rather than take each one piecemeal. And so to determine whether a global measure of metabolic vulnerability at birth can be used to measure risk for neonatal mortality and morbidity in preterm infants, we used our same birth cohort. We used kind of standard neonatal complications and developed a model to try to predict mortality and vulnerability generally. So essentially, when you look overall at these preterm infants, about 10% of them experience, or 9%, at least one complication of prematurity. And our final model included 6 clinical characteristics, several isocarnitines and amino acids, as well as TSH, 17-OHP, and GALT. And we had exceptional performance across the board in terms of really being able to use metabolic function to predict overall sort of survival without complications, otherwise known as mortality or morbidity as well. So if you see here, characteristics only gave us some prediction, metabolites only improved that, and then our combined model of metabolites plus clinical characteristics was the most predictive model. And when you look across gestational ages, this is true, whether we look at morbidity or mortality as a combined outcome. We also looked just at neonatal mortality. We looked at mortality to 1 year, and then each individual sort of contribution or complication, and then divided that by gestational age so that we could look just at preterm infants less than 32 weeks. But then we also looked at those later preterm infants who also, the model was also predictive for. And this was what I've been hoping to get to show you in terms of, if we look at, this is for all gestational ages, this is for those very preterm births less than 32 weeks, and then for our late preterm births, 32 to 36, sort of with the blue being, see if you can see that, protective, and the yellow being risk factors. You can see across the kind of spectrum, the contribution of each of these variables. I know it's not exactly what we were talking about last time, but I think this is also a good indication of their contribution to either risk or resilience. So that was all retrospective work based on the California data set. So now we're engaged in our prospective trial. I'm lucky to be funded by NIH R01 mechanism in a multi-PI, multi-site study with University of Iowa to evaluate dynamic metabolic models for predicting neonatal morbidity and mortality within the first week of life, with the plan to enroll 500 very preterm newborns less than 32 weeks across our 2 sites. We obtain blood spots at the time of other clinical evaluation that undergo their metabolic testing in Iowa. So they're obtained 4 times a week in the first week of life for all preterm infants, and then biweekly until discharge. And then I'll describe really quickly what we're doing with Joanna Halkis and others in the Benioff Center for Microbiome Medicine to look at the contribution of the microbiome as well. And can we start really getting a multi-omic look at risk and resilience in this population? So we've currently enrolled 42 infants here at UCSF, 128 in Iowa. We have a lot of samples that have been collected and tested, a lot of stored samples as well. And this just gives you a little sense of the scope of what we're setting out to do. So we're right in the middle and continuing to enroll every day, thanks to our amazing clinical research coordinators and collaborators. We are working, like I mentioned, with BCMM with their study, which they're calling PRIMO, nested within PROMPT, to look at premature microbiome and outcomes. So what we're doing in combination with the HOPE study, which is Dr. Julia Pulowski, one of my incredible collaborators and co-PIs. Her HOPE study as well is collecting a birth cohort, maternal and infant samples. So we collect all of these stool, nasal, skin, oral through HOPE. They're also collecting maternal, vaginal samples as well, throughout pregnancy, and then again, birth through to discharge. And then we've also added in under the PROMPT sort of heading, the COVE, which is our collaborators, Dr. Don Gano and Mark Peterson, who are looking at coagulation factors in the development of post-hemorrhagic hydrocephalus after severe intraventricular hemorrhage. So for this, we've added on blood and urine at cord at a week and at a month of life. So I just love this because I love that BCMM is collecting a lot of stool. So in addition to this, we have 8 COVE samples. We have 80 stool sets already in process, and lots of skin, oral, and nasal microbiome specimens being evaluated. So I hope that I've talked you through how metabolic function can at least help us better understand both gestational maturity, gestational age, mortality, and the development of preterm comorbidities. But I think the other important work that I do is making sure that all the research that we do, all of the initiatives and clinical care that we provide is done equitably. And I think this is something that Stephen Miller has started saying a lot better than me. So I'm just going to steal his tagline that of all the omics, he likes home. It's like, oh, now I have to memorize it. There's all these things, but he thinks the most important ohm is home. So I think we need to look at, this is just showing you that even despite all of our best care and understanding, neonatal outcomes really do distribute inequitably across race and ethnicity, in particular for our Black, Native American, Native Alaskans and Native Americans, as well as Black infants, having increasing numbers of mortality as well as morbidity after preterm birth. So this is something that is not explainable by any biologic factors, is rooted in, unfortunately, in racism in our healthcare system. And this is just a graph to show you that in some of the work that we've done, this first one, if you see here, this is mortality rate for Black infants compared to a white referent group of 1. So if a Black infant does not acquire any of the comorbidities of prematurity, they actually have a lower mortality rate. And this is controlling for a lot of different pregnancy and maternal factors, that just despite all of it, there's actually an improved survival rate if they do not develop one of the comorbidities of prematurity. Once they develop even one comorbidity, whether it's RDS, which again, most of our infants have when born early, necrotizing enterocolitis, or any of the common complications of prematurity, their mortality rates increase over that of expected compared to the referent group. So this we think really suggests that it's it's hospital level factors driving this really critical disparity. So to get at some of this, we know that understanding metabolomics, understanding microbiome, all of those things are important, and yet the care we provide is equally, if not more important. And so we're engaged in a number of these things in the ICN, including the REJOICE study, which is helping us understand the lived experiences, both of our staff and of our family members, and who report feeling the effects of racism in their care. And so we have a community advisory board that we're working with that will engage both in sort of QI improvement efforts, as well as evaluate and help with research studies to make sure that they're measuring important outcomes. And we're really adopting this strategy across the board here, as well as in multiple sort of statewide and national initiatives that in order to provide the best neuroprotective care, that it has to be family-centered, anti-racist, individualized, and rigorous through this great organization that was really spearheaded by our awesome fellow, Kayla Karvanen, the Neonatal Justice Collaborative. And this is, again, researchers, QI experts, family members from across the country who are really working to change the way we view neonatal outcomes and make sure that we're really investigating the underlying causes. So we really do this for our families who are amazing. And I want to have some time for questions. So to summarize, utilizing metabolic markers significantly improves mortality and morbidity prediction in retrospective cohorts and gestational age estimation in prospective cohorts. And hopefully we'll get through prompt to show the mortality and morbidity prediction in our prospective cohort as well. The strength of association with individual metabolites could help unravel specific etiologies and pathways behind complications. And we hope this will lead to more precision-based measurement and care for preterm infants. as with all we do, there's a need to understand context and where racism and other social inequities may impede progress, and make sure that we fulfill the potential of all of our patients. There are a lot of people doing a lot of this work. These are some of their photos, and I'll stop there.
Thank you, Liz. That was great. I'm going to take the prerogative as the moderator asked the first question. So I was interested that in your retrospective work that gestational age did not come up as a predictor of early death, because I think we often think about the most preterm babies being at risk for early death. And I was wondering if there was any potential loss there due to, for instance, not, the really early deaths, not getting the newborn screen in, and how you think that may impact your prospective work as well, since you recruit after birth, right? It's not a
Yes, we are recruiting
prenatal,
after birth.
not antenatal.
Yeah, no, I think the way that the work is done, really, if you just look univariate at all of these outcomes, gestational age remains the most biggest predictor of all of these outcomes. When we do the modeling and choose the cases, they're all matched by gestational age and birth weight. So they are not directly in the model based on the matching. So that's just why it's not coming out when you sort of look at the variables included in the model.
Oh yeah, that's right. Thanks. Yeah, I see. Okay. You have a comment, says amazing work, Liz, from Matt Center.
Thanks, Matt.
And Yao has the question.
Hi, Liz. So I had to step out partway through your talk, so I apologize if you already covered this. What were the sizes kind of your training set and then of your test sets to set up your model?
That is a great question. So typically, I'll just go back and I can show you some of the what we typically do is do a 2/3, 1/3 in terms of training and validation. But the number of, here, let me just bring this up, I can show you. But the numbers are, depending on what the outcome of interest is. For survival, obviously, the numbers are a little bit bigger because we include everyone when we're looking at different populations of interest. So for example, like for survival, the total, because we do this in a way that's case matched.
Yeah.
So we had 100 survivors here, but then matched it. But once they were matched here, it was 93 cases and 372 controls. So that was for survival. It's a little bit different based on, like, for IVH, we had 350 who had severe IVH. And then we did in terms of our 3-to-1 matching, or 1-to-4, actually, 4-to-1 matching, we had 1,400.
Okay. But to set up your algorithm, you said, as 2/3
Yeah.
or training and then about 1/3.
That's right.
And then are you planning to look at how the populations, that are being studied, like the geographic areas I'm thinking of in particular, will affect the variables that come out? Because, for all of these like machine learning type algorithms, the input is so important in terms of the characteristics of the performance of the test.
Yeah, definitely. And so we definitely take into account location. And I think, it's really interesting to me to see when you employ a particular algorithm, like we use the Iowa algorithm in Busia. And the whole point is to generate an algorithm that is both sort of generalizable, but also can be specific. So when we adjusted for the Busia population, we actually came closer to what we thought was prediction. So I think that's kind of what you're getting at, is that it's really important that you take into account that even if you come in and try to use a particular model, the hope is that you can refine that based on the local characteristics, because they are different.
Great, thank you.
You have a comment from Sanjeev, comment/question, whose mic is not working. He said, very exciting work, Liz. Did you see different metabolic signatures between female and male? I remember dogma being that preemie males, not that we taught Sanjeev anything in his life. I remember dogma being that preemie males had worse outcomes than females, but maybe that's been debunked in recent years.
Yeah, it's a great question, Sanjeev. So I'll say sex does not come out in particular as, although we do in some of our work match for sex, but it does seem like that is likely a debunked theory. There are some factors that when you look at individual, like the development of respiratory disease, for example, that there is still some suggestion, but I think our care factors need to come into play there too. And I want to just take the opportunity to specifically debunk. Kayla and I have a review paper, hopefully you all read, but there's also a theory that was out there that these wimpy white boys, I even hate to say it, that infants, Black infants actually did better in terms of respiratory outcomes. And actually that's been shown to be completely not true and may have led to like disparate care for Black infants than for white infants. So that whole idea is being sort of thrown out, changed.
But I think what you're getting at is that there, in terms of the sex differences, there are some animal models that suggest that in utero lung development proceeds differently in male versus female fetuses, which may impact some of those early and later respiratory outcomes.
Yeah.
Alma's raising her real hand.
I am. Hi, Liz. Fascinating. I have a million questions, but it looks like I can only ask you one. So your very last finding about African or Black preemies doing okay until something goes wrong.
Yeah.
Right. So can you flesh that out a little bit more? Like, what does that make you think about and how do you see that?
Well, I think that there are some really important things here to think about in terms of, again, care provision and counseling in particular, and how we counsel families differently after a complication of prematurity. And I think one place to do this is in the provision of active treatment at periviable gestation, to look at how counseling how implicit bias might or explicit bias might be playing a role in how families are disparately counseled. So I think that's one important area that we're actually looking at. Both Brennan Higgins is looking at that, as well as with Kayla and some others. So we're trying to sort of use that as a place where we might be able to really kind of pull out the impact of the healthcare recommendation or interaction. So that's one major way to look at that, Alma, but it's something that we're going to continue to follow and look at lived experiences of families as well. I want to get to Mary's.
So I know people are going to drop off because we're at time, but I think Mary might have a question about malaria or something like that. I don't know.
I mean, when I get to the malaria slides, I just say, can Mary speak up now? And
well, there's a lot of questions I would love to ask about malaria, but how much I was thinking more about the metabolic profiles and thinking about, of course, in the context of congenital infection, and how much do you think that they are altered by, I mean, of course, there's many potential congenital or kind of perinatal infections, and how much do you think that alters and how to, play into that when you're looking at these predictive profiles for, especially for gestational age and the interaction of these infections and preterm birth.
And I think that's why I think it's really important that we have Joanna and others who are helping us look at like immune response, which we can do with this multi-omic approach in an even obviously better way. I do think it's when we've looked at metabolic predictors with infection, that's historically and consistently the messiest variable. So we add sepsis into our algorithms and they just go like completely wonky. And that's true for a lot of the predictor algorithms that have been built for neonatal mortality, that sepsis is just so complicated. And when you're using administrative data sets in particular, it's almost like a useless variable. So I think we're stuck when we're with any of these retrospective studies and really trying to link with infection, but hopefully prospectively, we'll be able to tease these out better. So obviously we're collecting all neonatal infections in prompt, and we'll be able to correlate much better than we have been able to with our retrospective cohorts.
That's great. Thank you.
Okay, well, thanks everyone for joining us. And thank you so much, Liz, for sharing all of this. And we will see you again in, I guess it's 2 weeks. I'm not sure. In February. We'll see you all again.
Thanks, Roberta.